Hello everyone, welcome to the soft arthroscopic Latarjet procedure, whose technical principle depends upon soft tissue tenodesis of long head of biceps tendon to the upper border of subscapularis tendon, so that biceps tendon can act as a modified dynamic anterior stabilization sling for restoration of glenohumeral stability. As an alternative to sling glenohumeral stabilization mechanism of Latarjet procedure, recent different arthroscopic soft tissue reconstructive techniques have been described for management of glenohumeral instability. One of these techniques is transsubscapularis bony tenodesis of long head of biceps instead of coracoid graft transfer to the anteroinferior glenoid. For simplification of the latter technique, the current video reports an alternative arthroscopic technique for management of glenohumeral stability in patients with type 5 slab lesion or poor soft tissue quality of the anterior capsulolabral complex. In this technique, Bankert repair is followed by soft tissue tenodesis of long head of biceps to upper border of subscapularis tendon using two simple stitches of non-absorbable sutures. Compared to previous ones, current report technique is versatile, quick, technically simple, wholly interarticular, and cost-saving. However, it is non-anatomic and should be investigated in further biomechanical and cohort clinical studies in order to clarify its long-term validity. From biomechanical perspectives, as it is a soft tissue procedure that doesn't reconstruct bony glenoid, current report technique is supposed to offer 3 out of 4 of glenohumeral restabilization mechanisms of Latarjet procedure, including modified dynamic anterior stabilization sling mechanism by the biceps tendon, increased tension within subscap fibers, and feasible concurrent capsulolabral repair. Meanwhile, from technical perspectives, this soft tissue tenodesis is performed following Bankert repair according to the next technical steps. Firstly, through anterolateral glenohumeral cannula established 2 cm distal to the anterolateral corner of the acromion, a direct suture passer is used to pierce the long head of the biceps just proximal to its reflection pulley to deliver a loop of non-absorbable suture through the long head of the biceps. Meanwhile, through the anterior mid-glenoid cannula, a direct suture passer is used to pierce the subscap tendon at a distance of 1 to 1.5 cm from its superior border near its insertion into the lesser tuberosity to retrieve loop the end of the suture through the subscap tendon to the outside. Then a ring forceps is used to retrieve both free ends of the suture outside through the anterior mid-glenoid cannula. One free end of the suture is passed within the suture loop and pulled, thus driving the loop down the anterior mid-glenoid cannula till resting tightly over the long head of the biceps. This step ends in a fixed knot which firmly holds the long head of the biceps and subscapularis tendon to each other. This knot is further secured by 6 alternating half hitches. Similarly, another loop of non-absorbable suture is passed within the long head of the biceps in a more proximal location for a second stitch, suturing again the long head of the biceps to the upper border of subscapularis tendon while employing the previous steps. Then, tenodesis is completed by tenotomy of the long head of the biceps from the superior labrum using a combination of diathermy probe, soft tissue biter, and motorized shaver blade. Finally, integrity of soft tissue tenodesis of the biceps tendon to the upper border of subscapularis is checked by probing prior to closure of the portals. Much thanks.